Hi, Assalamualaikum and welcome back with me, Dr Nurhamizah Zulkifli, to our monthly Sinar Daily's Laugh and Style podcast, your trusted platform for in-depth discussion on medicine and health. And today we have with us very special guest, I would say an expert in brain surgery, to discuss on when the brain bleeds, trauma, aneurysm and also pregnancy risk. Dr Moventhiran Ramakrishnan, welcome to our show. He's a neurosurgeon with extensive experience in treating critical brain conditions, especially intracranial bleeding, traumatic brain injuries, and also neurosurgical emergency. He's currently practicing in Hospital Tengku Ampuan Rahimah, Klang, as well as also Hospital Shah Alam, and also occasionally he will be in Hospital Sungai Buloh. Basically, he covers all neurosurgical services in Selangor. Dr. Moven is he's just operated on a heartbreaking case involving a young pregnant woman with aneurysmal bleeding, and we hope this conversation will bring both insight and awareness to these life-threatening conditions. So in this episode, we will delve deeply into the causes of intracranial bleeding, which ranges from trauma, hypertensive bleed, and also to ruptured aneurysm, the signs and symptoms, which are the warning signs, which normally present with headache. So he will elaborate further, when headache is a warning sign, management and surgical interventions, and also to explore the rare and devastating causes like intracranial hemorrhage in pregnancy. So, Dr. Moven, let's begin with this. So first, we would like to go into the technical matters per se, the scientific matters, medical matters of what is intracranial bleeding, yeah? To start off, how do you actually define intracranial bleeding and what are the main types that you encounter?
So, hi everyone. So basically, when you have a patient in your emergency department that came in due to a brain bleed, we always divide into whether this is due to a trauma or accident, fall. And number two is disease caused by any like hypertension, strokes, medication. And this is a two contributing factor for my workload that I have to travel everywhere to work. All right. So in daily practices, we divide this into a spontaneous and traumatic. In spontaneous, we divide into that hypertensive bleed and also other cause of stroke, and also the spontaneous in the young patients, like example aneurysm ruptured, AVM ruptured. So this is another cause of the brain bleed. But our main load, like I said, this is a two main load of my working schedule.
Okay, so basically, how do you actually divide it? Like you said, you have trauma, normally accident-based, or you can have spontaneous. Sometimes you have malformation in the brain, which suddenly can rupture, or due to hypertension as well, right? Okay, so from your experience, Dr. Moven, what are the leading causes of this intracranial bleeding? As you say that you have traumatic and also the spontaneous. Which one would you see more, especially in Malaysia?
All right.
The trauma outrank the hypertensive bleed and also the aneurysmal bleed?
So, all right. We divide this into a two, one based on the age group. If you have a young patient, usually it's due to a trauma. Like in the statistic of Malaysia, every 60 minutes, there are one head injury going to happen everywhere in Malaysia. That means we have about every day, about 18 to 24 cases of head injury that happen throughout the Malaysia. And also now we move on about stroke. Stroke is a third leading cause of that in Malaysia. So sometimes you have a patient that referred to me like because of a hypertensive bleed, sometimes because of a MCA infarct. That means there are no bleeding yet, but it's already start to bleed. And also in a very rare occurrence, in a week you get 2 or 3 aneurysm ruptured. So this is the most how we divide the patients. But like I said, the age group, trauma usually the young one, and the in the elderly patients, more not elderly, I mean 60 and above or 50 and above is hypertensive bleed. This is how we divide usually.
Okay, all right. But like what you have heard that Dr. Moven said, 1 in every 60 minutes.
Yes,
you would have a road traffic accident, and that would cause some intracranial, some injury. It could be bleed or just traumatic brain injury. So imagine the workload that he is facing every single day, especially in Selangor. Yeah. So since you already know the, I would say the etiology, the cause of this bleed and how we divide it, maybe you could walk us through in terms of the signs and symptoms. For example, what are the typical signs and symptoms that the patient would present? Or maybe the family members would pick up. Most of the time, they always being associated with headache, yeah, and sometimes blurring of vision. So, and how does it differ between the etiologies? Which symptoms comes first?
All right. Basically, brain, the first warning sign, example, in the spontaneous bleed. Because trauma, usually they already come to us in the emergency department, so we usually don't need the specific sign for them. But in a hypertension bleed or hypertensive bleed or stroke or aneurysm ruptured, the number one causative symptoms is sign and symptom is headache. So they will complain a mild headache, light headache, which is like a person might be normal all through. They not been diagnosed with hypertension, but they will say, I have a headache today, but the headache is bad, it's kind of bad. And subsequently, they will start to have other symptoms like vomiting. This is sign of a raised intracranial pressure. And subsequently, brain is a very specific and beautiful structure. That means if you have a bleed in a certain area, you have a certain symptoms. Like most commonly in a stroke, in a hypertensive bleed, usually in a basal ganglia, which is 58% is in a basal ganglia, they will come with the weakness. That means unilateral weakness. They have a weakness of the right arm, left arm, and also a right leg, left leg. It depends how big the clot and how severe the bleeding is.
Okay, so mainly, so if you have a headache, so now we would like to go, because I think headache, if you just, any Tom, Dick and Harry out there, if you ask them, they would have headache, isn't it? And especially and they will always attribute it to stress, not enough lack of sleep, those things, and easily being misdiagnosed as migraine. So when does it, that these people, when they complain of headache, but this should raise, this is like a red flag signs that this is something which is not just a normal headache, and they can't just be brushed off from the counter like that.
All right. In this kind of brain bleed especially, so we in hypertension, the headache is always in a very short term of time, because they will associate with other symptoms as well, like weakness. So sometimes they don't tell they have a headache for 1-2 weeks or 3 weeks before of that. And so it can happen like you wake up, you go for your breakfast, suddenly you are sitting down, you have a headache and you drop.
Okay.
That means it's very sudden. But in aneurysm ruptured, example, this is a very specific. So this is a typical sign that always miss actually. In a 1 or 2 weeks before the major incident to happen, they will start to have a headache.
Okay.
That means the headache is like, something is like, why I got headache? Because I'm not a migraine person. I was not in a migraine medication or anything. So what happened? We call it sentinel hemorrhage. That means the rupture of aneurysm start to happen slowly. Irritates the brain and brain gives the symptoms.
Okay.
But on the day of the event, they will have that. They know this is my thunderclap headache. This is the bad headache that I never had before.
Okay.
You might be lucky if you can walk to our emergency department, but most of them will came in a reduced conscious level. But when they wake up, when we ask them, they will tell that is that headache that I won't forget in my life.
Right. So like, for example, this aneurysm, especially because if trauma, normally they will come and then they will bleed, and then they're already in emergency department. Those with the hypertension, normally most of them they will know, because they will tell they forgot to take their medications. When they check their blood pressure is high. But this aneurysm is like a silent killer. I mean, it's a bit, I mean, they just have headaches. But for example, how would you know? I mean, is it like something? Will it, like, the intensity would increase regularly? Like you said, they will have prior to that few weeks before.
Yes.
I mean, sometimes they just take Panadol Actifast and just goes away. Is it something which is okay for us to just brush it off?
All right. This is way balanced. You have to balance. All right. In a country like Japan, so when I went for my attachment in Japan for vascular, every patient who have a headache, they will get a CT scan or MRI be done to them. That's why their pickup rate for aneurysm ruptured are very, very, very fast.
Wow.
Compared to compared to other countries, all right? Okay, because the accessibility of the CT brain, how your medical knowledge that you are available in the certain country, like Japan, example, they clip aneurysm because we do a clipping of aneurysm almost every day, like because they diagnose it, patient is healthy, patient are very healthy, then they go and clip the aneurysm. But for us, is it like example today, tomorrow lah, I got headache. How fast I need a CT scan,
Yeah,
right?
true.
But that's the reason we said it's a very very much in dilemma. If you have a headache more than a month, more than 2 months or 3 months, I will always say don't take Panadol.
Okay.
Take a better solution. Do a CT scan, do MRI, because you have to understand we are moving in the current era of the world. Our bleeding rate in the young patient age group, especially 30 to 40, increasing. In my practices, I've seen a lot of aneurysm ruptured. Usually we see aneurysm ruptured in a young prospect of age group. So if you able to do a CT scan when you have a headache, is a very big relief in your life lah.
So basically, that's a very important point for not just those in the hospitals, for our audience out there, but also I think for the general practitioners also, because sometimes it's easily that easy way out is we would say, oh, this person would have a migraine, so we just start them on migraine medications. But sometimes there could be some more sinister pathology in the brain that needs a CT scan. So I would say, like as per Dr. Moven said, if the headache is very much frequent, constantly coming, and sometimes there's no precipitating factor, it's better to just write a referral letter to the higher institutions for them to proceed with the CT scan.
Yeah, right? I think better. It's okay to overtreat. Compared to undertreat. I mean, I always tell, I always have get a call from my friends in the general practitioner, especially Chief, what do you think? I say, to be clear, to be safe, why don't we get a CT scan? Because it will tell you better and also clearly any pathology in the brain. So I think better be safe lah, because it's okay to overtreat. That's always my theme of work lah.
True. So because I think that's how we need to move forward. Like what you say in Japan, it's very easy for them to get the CT scan or the MRI or the CTA, right? And then when you pick up early, so you can intervene early and you can prevent all this catastrophic injuries to the patients. So Dr. Mo, I just want to ask, is there any common misconception in the patients that you treat, or maybe in the society when you give your talks, especially when it comes to headache, when it comes to all this blurring of vision? Sometimes they would say, like I said, they would just brush it off saying it's migraine, it's not important, I don't need to be treated. So what are the common misconceptions that you have received when you, as a neurosurgeon?
Common misconception is, we talk about stroke first. So when in a stroke, first of all, if you diagnose with hypertension, make sure you take your medication, right? So the problem is the misconception, if I take my medication and my BP is back to normal, I can stop it. So when they stop, because the last follow-up, example 6 months ago, the BP was 130 or over 80. So, okay, I can stop my medication. And after that, after 6 months, you will have a hemorrhagic stroke because your BP was not controlled. So this is number one. Number two is always like, I have a headache because my daughter never sleep over the night, right? So, of course, but you have to see, why is keep on coming. But thank you, because nowadays we have a lot of, I think we have a lot of influencers giving out a lot of positive thoughts that you have to do investigation, you have to do your all this follow up with the doctors. Our pickup rate is increasing in trend, but in somehow we need to approach overall population. We cannot miss in a town, but in the outskirt, you miss a lot of things nowadays. Especially when I got a patient from, because I cover the whole Selangor. So especially when you have a patient from Tanjung Karang, from Banting, because the availability of like, you need to do this, you need to do that, like follow up with your doctors, or it's very far for me to see a neurologist or neurosurgeon, but you have to come.
Yeah.
Right.
But I think that's the baby steps that if you can see our Ministry of Health that we are trying to open up more hospitals, try to give outreach those further part in the like we say the kampung-kampung, in the distant areas, and even I think like Dr. Moven said that for Banting, although it's quite far, but we have is what we call a cluster, so they could actually send the patient over to Klang. And then they have Shah Alam also, they are covering. So although I think neurosurgical services are expanding tremendously in Malaysia, I would say.
We are expanding currently because we get more numbers of neurosurgeon that's coming out. So, but the workload also expanding because like the pickup rates, like I said, the screening program, and also the awareness of the population that our workload is increasing, but it's okay because we want to treat them, right?
Yeah, if you can follow Dr. Moven's Instagram, he's very enthusiastic, a neurosurgeon, I would say. So moving on, since we have already talked about the signs and symptoms or the red flag signs of headaches, now you move on to trauma, because you are in Hospital Tengku Ampuan Rahimah Klang, which is, I would say, the hub of trauma, and it's a trauma center. How about in head trauma cases? What are the signs that you would raise a suspicion that there is an intracranial bleed? Because sometimes not all patients which have probably some bruises over the head that they are having intracranial bleed. But when they arrive to the hospitals, what are the possible suspicions that you have if this patient might have a bleed inside the brain?
So, like I said, I am in a Klang for a year. I think we operated almost 370 cases in a 12-month, which is only purely trauma. So once you came to our emergency department, so we have a screening. So we will see how is it the high impact injury or low impact injury. How fast you drive your car. Did you wear your helmet? Do you have any bruises? Like we have a specific sign. We look raccoon eyes. Like example, your eyes having a blue black, and also you have a battle sign. You have a bleeding behind your ears. This is a very suspicious. This patient might have a intracranial bleed. And also basically we go by a scale assessment. We call it Glasgow Coma Scale. Like how conscious are you? How conscious are you? Like your GCS level. That's a very key premium indicator. But nowadays, like I said, the availability of CT scan is wide. All right. So if you are suspicious, like we better do a CT scan. So even we don't find anything, but better be safe for the
like
patient.
You said, better be safe than sorry, right?
Sorry. So like example, like the development in Hospital Banting. Thank you KKM. They put a CT scan in Banting. So the pickup rate of a head injury in Banting is very fast, and we manage Banting cases are very fast. And also now they are moving neurosurgeons. Like I moved to Shah Alam to operate. I moved to another hospital to operate. So we give the best timeline for them. But the key symptoms, you come in, usually the emergency physician already know, okay, this patient need a CT brain, but they never say no for CT brain.
Yeah, it's very easy to get a CT brain because nobody wants to be held responsible if there's something wrong up there and you did not do a CT brain, right? So like what he said, Dr. Moven has mentioned in terms of the consciousness level, which they have their own scale, and then in terms of the signs that they have, the like blowout signs, the raccoon eyes, and then also the bleeding sometimes from the ear, nose, and bleed, and the from the ear. How about, so once you have, for example, diagnosed a patient in the trauma setting, in the emergency department, that they have intracranial bleed, what are the key factors that you would determine this patient needs urgent, I have to do the surgery within 1 hour, 2 hours, 3 hours time, or I would say 1 hour, right? What's the joke? It shouldn't be 2 or 3 hours. So 1 hour. And there are certain cases that you say, okay, this one maybe wait and watch. After 24, 48 hours, you repeat another CT brain. Or this one you would safely say, this one is okay. No need to repeat CT brain. Just maybe you could discharge after 1 or 2 days with a head injury advice. Yes. So which one would you? How do you tailor your management?
So we follow the guidelines. We follow Brain Trauma Foundation guidelines. We follow Malaysian Trauma Foundation guidelines. The moment you look at the scan and also the patient as overall, you look Like example, when you have an extradural hemorrhage, it's a bleeding in the brain that caused by a trauma most commonly. You know it's more than 10 mm. It's very confined space, right? So when you have anything more than 10 mm, you have like midline structures are pushed away, your conscious level is low. Say don't wait, go in now.
Okay.
But very small contusional bleed, right? You can see like a patches here and there. You say okay, wait and watch. Tomorrow we repeat the CT brain after 24 hours. Sometimes we even repeat a scan because sometimes we have a guideline. This clot can expanded in this location. Say after 6 hours.
Okay.
So that's why my radiological colleague is like, why you always repeat a CT brain? And of course, example in neurosurgical places, even before I was in HTA, I think even general surgeons was like, now when neurosurgery come, they have the priority because we always say time is brain.
Yep.
Because like I said, the moment I receive the patient, I receive the CT brain, my decision will be within 10-15 minutes. Then after that, we push to OT within 1 hour. So we want to optimize the operative time and time is brain, the trauma time.
So you were saying 10 millimeters. That is actually 1 centimeter
Yes.
bleed. The width of it inside the brain. That itself can really cause a massive effect to the brain itself. Yeah.
Yes.
Okay. So remember, maybe some people thought just 1 centimeter is not just like a very small little tiny bleed, but it actually can cause a catastrophic disaster. Okay. So can you share a case where immediate surgery changed the outcome dramatically for a trauma patient? Because sometimes some people they feel that when they have to undergo, especially brain surgery, it's something which is very major. Of course, brain surgery is major. I would say even if you just make a hole or you have to remove your skull, it's already a major surgery. But how would you in your practice that you would to convince, because I believe sometimes it's not very easy to convince the patients or maybe the family members, because most of the time the patients are already unconscious, they've already intubated, they have tubes and they can't give consent by themselves. So in your practice, what are I would say the challenges that you have faced in terms of getting you're very enthusiastic to push the patient to OT, but you have issues with the consent. Sometimes they are worried, that the public is worried what would be the outcome. But maybe you could share some of your experiences that after the surgery they really improve after that.
Okay, the challenge is actually the surgery itself. All right. So first of all, when you tell I'm going to do a brain surgery, everybody is like the eyes are going to open up. You know, it's like really. So yes, but in the condition like what we are talking today is do or die. Example, if you do, you have a chances of surviving. If you never do, the high risk, the high likely, the high percentage that you're gonna pass away. So my option I always give to the patient is like, what I doing today is life-saving surgery. It's not like I gonna make sure that he can walk back or I make sure he can like function as a normal human. I say no, at this moment, this time, you have 30 minutes to decide. For me, it's like do or die.
Yeah.
So I will explain everything like regarding what are the possibilities that he might be in ICU for 3 months, 4 months, but the decision still in the family hand, right? So sometimes the challenges is like family wants to talk somebody like, doctor, I want to have a meeting with my family. So when you ask when is a meeting, said tonight, I say no, you have no time. It's like I need it. I give you maybe 15 minutes, 20 minutes, because like the decision making is something is very big. Because like you told me, how you mentioned just now, even putting a small hole in on your skulls and going inside the brain also, people think a lot. But in a dire emergency condition, they said the decision must be fast. So that's why we said we give them time and we try to convince them. We try to explain what are the possibilities that can happen. Like I might come up with my own statistic that what I did, my experience. So they might agree with you, then we proceed. In certain condition, they will refuse. So when they refuse, we have to respect the patient choice, a family choice. Then we have to ask them to sign the against a refusal form.
Right. So, for example, like you said, in terms of what are usually the recovery phase? I mean, in those cases that you operate, that they were initially unconscious, and then they can actually the next few days they recover. I know it depends on how severe is the injury, right? But have you seen? Most of the time, if they operate today, and then maybe the next few days, 1 week, you can actually see them start walking, be awake, and
okay. So it depends on what type of bleed you have. Like example in the extradural, that means bleeding outside the first layer of the brain.
Okay.
Even they came in a condition like even the family member said he can live like after you do the surgery, they can wake up the next day. So I become a miracle worker. But it's actually the nature of the injury, right? So number two, it depends on a lot of factors like how bad the injuries is, where is the bleeding. So sometimes most of my patients in the acute setting for acute extradural is usually they wake up within 2 to 3 days if everything goes well.
Yep.
And also in subdural, we give them some time, 2, 3 weeks, 4 weeks. In the contusional, big contusional bleed, they might go longer. I have patient who stayed with me for 360 days, another 5 days. I tried to discharge him before it complete 1 year. So yeah, I managed to discharge him, thank God. So yeah, so the recovery depends on what type of bleed, how severe, how bad you came in. But somehow the aim is life-saving.
And then maybe you'd like to add in terms of why is it brain surgery is something that you really need to make the decision fast. How brain is a bit different because they don't regenerate, right?
Yes.
This is, I think, what the public should know, because there are certain parts of our body, like our nails, if you cut, they keep on growing again. Okay, there are certain parts of our bodies, but not the brain. And they are very susceptible to the lack of oxygen. So maybe Dr. Moven can just shed some light.
Whenever you have a brain injury or even bleeding in the brain, we said the golden timing is only 4 hours. Why? Because the brain gonna start changing. So the area bleed gonna stop the bleeding for a while, but what happened that infarct is coming in. Infarct means there are no enough blood flow to the brain and the area is like goes off.
Okay.
So when it goes off, there are no way I can do any miracle to
reverse it back.
So we try to avoid this reversible injury. So that's why we say within 4 hours. That's why I have to push. Sometimes we open 3 OTs one time. Like example, I will operating 1 OT, my registrar another OT, my medical officer another OT. Because we say brain is time.
Yeah.
So that's the time because it's very, very fast. Usually when you have no oxygen to your brain for 8 minutes, you already have brain damage. That's why our CPR must be fast, our intubation must be fast, our surgery must be fast. So, that's why my people say, neurosurgeon, everything fast. Step.
Pronto,
So my order is very simple. I want now. So yeah.
So I guess that's the take-home message for the publics out there. Decision making must be fast, and also for the medical practitioners, for you to consult the neurosurgical team, have to be very fast. Any suspicion, I think Dr. Moven and his team is very open to their phone. They would just pick up even 2-3 o'clock in the morning, because I have referred cases to him. If I think that it's very urgent intervention, I'll just give him a call at 4 o'clock in the morning, and he just wake up like, hello, Miza.
I'm trained for it.
Yeah, I'm trained for it. Yeah. Okay, so let's move on to a bit more, I would say, tricky subtopic in intracranial bleeding in pregnancy. So the case that really shocked us, right? I know this is not your first case that you have operated. Okay. We're not going to go into the detail of the surgery itself, but recently you managed a tragic case involving a pregnant woman with a ruptured aneurysmal rupture. So can you share with us in terms of the what makes managing intracranial bleed in pregnancy particularly challenging? Because as you know, being pregnant is already, I wouldn't say it's a disease, it's already a change in the condition of a human being, and then somehow on top of it you add on another pathology. So basically what I'm trying to say to the public out there, any department wouldn't want to touch a pregnant lady, because it's a very, very I would say high risk cases. So how is it challenging in managing a pregnancy with the intracranial bleed?
The first word challenging is pregnant lady.
Yeah.
So the moment my medical officer will call, say, boss, I have a pregnant lady case. You know, even at what time our eyes are wide open, we won't even see the scan. We will just jump into our computers or laptop to look at the scan, because our decision need to be very accurate and fast. So when you're pregnant, your body changes.
Yep.
So your blood flow is increased. So what happened with this? This is a time when something that was not diagnosed can be diagnosed. Like mostly the cases like that I operated and I experienced throughout my service, usually they don't know they have aneurysm.
Yeah.
They don't know they have a AVM, because if they were diagnosed before the pregnancy, we will advise them in a lot of methods what you're supposed to do. So what happened was the blood flow changes, the hemodilution, because your blood become thick, sometimes thin, and you'll be on medication, and sometimes you can be stressed, right? And you can strain and everything. This caused the blood flow to show up, increase more to your brain, and the basic pathology is the aneurysm might be there. Like like I said, one out of 10 of us might be walking with aneurysm. So what happened? The body changes caused that symptoms to start to appear, like particularly go back, they will have a headache. So this headache in pregnancy is always a red flag sign, and you have to understand this is where we become a problematic when they have a light headache, because CT scan are not safe for pregnancy.
Yes.
So we need to do MRI for them. So sometimes they will say, okay, we push for the MRI, but in a dire emergency cases where they already in your emergency department, we say we have no choice. We have to proceed with the CT brain. We have to become mother first.
Yeah.
We try to save the mother first. But it's very tragic because aneurysm ruptured is 1 minute time bomb. I will say not 30 seconds, because you are talking now, you can drop in next 30 seconds. So in this case, like particular case or certain aneurysm in pregnancy, it never be small. Like example, that size is not like 2 mm or 3 mm, can be 10 mm, can be 15 mm. Sounds small, but when you do a surgery, we call it a giant aneurysm. It's called it giant, anything more than 10 mm. 15 mm. So, and when you have a giant aneurysm in pregnancy, that make you to sit down, think, what am I supposed to do? So this is where we will call. I say, you know what, you have to take out the baby. I have to operate on the brain. So I think most of the time, sometimes I'll be waiting to start until the baby deliver. The moment I heard the baby sound like crying, okay, I said, can I start? Can. So I start. So this is the pathology is already there, but the body changes cause the appearance of the symptoms happen.
So basically what I'm trying to say is that it just exacerbate the whatever, because I think not just brain aneurysm, it seems goes to sometimes those who have valvular heart disease, they could be undetected. Then once they are pregnant, then everything will just set into place. You can see all the hemodynamic changes, meaning that because their pressures would be much more, because they need to support another living baby inside, right?
Yeah.
So all these hemodynamic changes, you can just increase the pressure, and everything will just going to be a haywire inside the body. So like you have just mentioned, if in an emergency condition, yes, CT scan would be, because basically you would just want to get the diagnosis, because once the bleed is already there, just a plain CT scan, you can see the bleed. But those who have subtle symptoms such as headaches, maybe they are pregnant but they have these headaches, and I think with our podcast, maybe most of the pregnant ladies out there are a bit more worried, so they
might have a headache now.
So they every time they have headache, maybe they might be thinking. And then what would be the better options? MRI? I mean, is it really safe?
MRI is safe for your pregnancy, which is accessible and safe. Even everything have a risk, right? But rather than going undetectable with your aneurysm, AVM, better to do MRI. If you indicated, example, your headache getting worse and worse and worse, and your BP is normal, you're on medication, and you start to have other cardinal symptoms, like you have blurring of vision, you start to have some weakness or some other symptoms, I think we say don't wait, push for MRI. MRI, because in MRI we do MRI, MRA, MRV, MRS. There are a lot of fractionated in MRI. So for us to study the brain properly and see, this could be the cause.
Okay, so meaning that even you would say that of course anything would have their risk, but MRI is relatively a safer choice as compared to CT scan, or because this is based on their radiological, the radioactive imagings, right? So if you have, like you said, when you had the patients with the aneurysmal rupture, or maybe those who are not ruptured yet, and you manage to detect it on MRI, is it safe for them to undergo intervention when they are still pregnant? Because if they want to wait until they complete their pregnancy, then they are at risk to have ruptured. But are they safe to? Is it safe?
This is where we come in the multidisciplinary talk. We will have a discussion with the obstetric and gynecologist, our interventional radiologists, and everybody say, okay, the option now, I say, example, we have a patient with aneurysm. She is now 24 weeks or 27 weeks, because usually this happen in 24, 27, 32 weeks, right? Okay. So we said, can we deliver the baby? So because my concern is I need to clip without, I don't want to cause any harm for the baby. So I'll have to open up the question to the floor, to the everybody there. Is it safe to deliver the baby? So when you have a neonatologist support, you say can. So he said, can ONG are willing to come in, can we take out the baby, you settle your brain part. Right. So it's a win-win situation. Okay. But when this is undetected, in the aneurysm, usually, in my statistic, we have a lot of aneurysm last year, past 2 years, especially in Selangor, increasing in rate, especially in pregnancy. Sometimes we have to say, we deliver the baby, in the same time we do the surgery. Because aneurysm clipping is a very complex surgery, because you have to spend a lot of time, and as a neurosurgeon you spend a lot of time under your microscope to find the aneurysm. It's not easy, because if a tumor is there, it's a blood clot is there, but aneurysm you have to trace from that first branch of your blood vessel, and you have to look, where is it. So sometimes took me about, I had aneurysm, I clip after 18 to 20 hours. So because we cannot find it, so we find until we reach. So very complex, delicate. So we have to decide every overall. So especially for the baby. But in the early pregnancy, this is a problem. So we have to, I think usually one case we have a AVM. AVM is a arteriovenous malformation. We admit the patient from 8 weeks of pregnancy. We waited her every morning without fail. I'll go and see her in the morning, and before I go back, I'll see, are you okay? Do you have a headache? No. Okay, stay here. This is your home. She was there until 32 weeks. Thank God we delivered the baby, and I excised the AVM. And after the excision, after 2 years, she pregnant again. So congratulations. She messaged me, she WhatsApp me and said, Doctor, I'm pregnant again. Is it safe? I said, okay, I think the last MRI clear for you for pregnancy. Please go on.
Okay, right. That's successful stories from the aneurysm. So it's very important for not just the pregnant ladies. I think for anyone who has headaches and then you are a bit suspicious, don't worry. Like we just mentioned just now, just get yourself checked. Don't hesitate, because this is actually the aim of our podcast, to create the awareness, to make sure to we don't want you to sit in the dark and not sure what you need to do after this. So since we've already talked about the imaging, the signs and symptoms, now we would like to move on in terms of the innovations, in terms of you have mentioned the CT scan, plain CT scan, and then you have the CTA, MRA, whatever MR that you have, MRS. How is it different? We don't want to go into detail in terms of the radiological terminologies, but when do you decide for CT scan? Just like a normal trauma is a CT scan, on like you say aneurysm is MRA. When you decide for all these things?
Okay, number one is based on our experience. Whenever you see it, because the number one rule is whenever patient, they will come with a plain CT brain. Whenever you look at it, it's like, hey, this doesn't look like a normal stroke bleed, right? Okay. Why don't we get a CTA? Once you get a CTA, this is an aneurysm, because the bleeding itself they have the pattern.
Okay.
They have the first picture. They're gonna tell you what am I there. So like aneurysm, they have a star-shaped sign. The moment they put up the scan, like people like me will say, "Hey, this is aneurysm."
Okay.
So this is a hypertensive bleed, and we'll say, "Hey, this is a tumoral bleed." So because we experience this is a pathological how you learn before you become a neurosurgeon. You must know this before you become a neurosurgeon. So there.
Okay, so basically it's based on maybe the initial screening that they would do is just a normal plain CT scan with no contrast. Then from there, once depending on the bleed, the nature, and then maybe the history. That's very important in terms of the history presentation and also the imaging, the initial imaging. Then you would actually decide if you need further imaging to confirm your diagnosis. Yeah. So. You have been a neurosurgeon for, I would say, 5 years?
5 years.
5 years, okay. So what are the advancements in neurosurgery? Okay, you have talked about how is it like in Japan, how they have detect aneurysm very, at the very initial stages. Maybe here in Malaysia, what are the neurointervention and like the neurosurgical, the new advancements that you have seen? Maybe you want to share what you have outside Malaysia and also in Malaysia as well, and how it has have a significant improvement on the outcomes of the patients.
There are a lot of advancement, especially even in Malaysia itself. Like take an example in the center that Hospital Sungai Buloh, like a neurosurgery team in Hospital Sungai Buloh, we are known as a neurofunctional center.
Okay.
So what we do, like example, we do, we put a lead for the deep brain stimulation for Parkinson patient. Okay. And patient will be awake throughout the surgery, and we put the lead, and it reduces the Parkinson. In like my area of expertise, example, I love, not to say I love, I prefer
forte.
to. It's my forte.
Your forte.
My forte is more like I love tumors.
Okay.
So I like to take out the tumors from the brain. So we have like example in a high grade like tumors, we give a dye that gonna lights up during the surgery. Example, I will be in a dark room and the tumor will be there. So under my microscope, I try to take out as much as I can. Okay. And we have a intraoperative radiotherapy. We open up the patient and we give a radiotherapy while operating. Okay. Of course, it's a risk, but we want to give the best outcome for the patient. The advancement is that spinal cord stimulation, transmagnetic stimulation. There are a lot. And we are doing it in Malaysia. We are not far behind actually, because most of our neurosurgeons are certified for all this advancement, and we always been sent out by our department to go for a training, come back. It's not just training. You come back, you have to do it. Yeah,
you have to practice it.
You have to bring
the new things.
Make sure what I send you is worth it, and you come back and do it. All right.
Okay. And then actually, maybe just a little bit of neurosurgeon. They are just not operating on the brain and the brain matter, but they also do the spinal cord and also the spine injuries as well, right, Dr. Movent? Yeah, so it's not an easy task for them to manage. Okay, so what is your, before we move on, I mean, we are almost reaching to our last few questions. What would you be your message to the general practitioners out there, or maybe the emergency doctors, emergency physicians, especially in the rural cases? Sometimes I think there are still certain hospitals which they don't have the CT scan, so mainly they have to basically go by their clinical findings, and how to act fast in suspected ICB, intracranial bleeding cases.
So like I said, when I was a medical student, the most one of the hardest topic is neurology. Right? I think we don't like neurology, right?
Because the problem is brain is something which is not properly understood until the day itself, right? There's all these new things that are coming out.
So when I was an undergrad student, I always tell, why is so hard to understand? So it's like, that's a topic you don't want to give, like, it's okay, I won't be anything to do with neuro in the future. Then after like 5 years back, they put me as a neurosurgery medical officer. I was like, okay, and now I'm a neurosurgeon. So it's basically the knowledge. You need to equip with the knowledge. Like sometimes there are certain signs, it's very, very much subtle. Example, your eye movement. Like example, you have a stroke and suddenly you say, might be a stroke. Right? When you do an examination of your eye examination, you have a nystagmus that pointing that, hey, this is a stroke.
Nystagmus is actually
the movement of the eye towards, we call it a firing of the eye.
All right.
So this is you just move your finger, you know this is a stroke bleed.
Okay.
So the district will say, you can talk easy lah, you're a neurosurgeon. But always equip your knowledge and make sure you know. If you, like for me, for district, any district that call me up, I will say send over.
Okay.
I said send over.
Right.
Because we cannot be jack of all trades.
Yep.
We cannot be, I'm not good in obstetric and gynecology or you cannot ask me to do a laparotomy. So I cannot open up abdomen, right? So but sometimes it's okay. You have a limitation, send over. If you have any doubt, always reach out. That's all.
Because I think nowadays Malaysians, I would say the Ministry of Health, our health services has expanded tremendously, and like I said before this, we try to reach out to those which is the far, in the rural areas, and we are always there. Those we are in the urban areas, they can always send over. Just the problem is sometimes it's the transport, the duration. The doctors will always be there because we don't sleep when we're on call, but the problem is it might take some time for them to reach. So that is very crucial. The time of referral is very, very important. Do not delay. Any suspicion, any doubt, you can just call up Dr. Moventhiran.
Yeah.
I mean, whoever the neurosurgeon.
For example, what happened recently, I would say, so funny. So I told my wife about this case because I was on call, but I was looking through my phone.
Yep.
Suddenly, I see a TikTok message. I was like, okay, usually I won't open my TikTok message, but I see a doctor name, particular doctor. Say, boss, I'm from hospital here. This patient have this problem. Can you help me? So I said, okay, why don't you WhatsApp me lah? So when the particular doctor WhatsApp me, I said, this is a brain tumor. I said, this is a very big brain tumor.
Okay.
I said, boss, how do I send? I said, you tell you've spoken to me, send the patient now. And when the particular doctor sent over the patient, and she followed the patient.
Yep.
Until my emergency department. And I said like, how you get this referral? I said, TikTok. But thank God we managed to operate this patient 3 weeks ago, and patient is discharged home. But that is a fast action, and the way they are trying to reach you, I cannot get your number, I don't have your number, and this particular doctor, I can't recall her name, but I think she did a great job.
Yeah, so basically she tried to reach out wherever she can, and and then you can find, sometimes you don't find his name, like I think Moven's name on TikTok is Moven, but on his other things will be other, maybe we will tag later in our podcast.
I try to hide my identity as well to reduce my referral.
But most important thing is that if you have any referrals, if you can't go get through the WhatsApp, because I always make a point that I will WhatsApp if it's an urgent case, 1 or 2 minutes maximum. If I don't get the reply, call anytime, because most of the time we are on call and we are supposed to be awake and managing the patients, right? So I found a question is that what would you say to the general public, since just now was more of a medical I would say message for the healthcare workers, in terms of the general public, what should everyone know about recognizing the early signs and getting immediate help, like about do not delay the 8 minutes rule, make sure the decision making must be fast, make sure you bring if there's any symptoms, anything else that you would like to add on for the general public out there?
So for general population, I will say, first of all, make sure you get a correct person to give you the advice, because there are so many advice.
Not TikTok, not non-credential doctors on TikTok. Yeah,
there are so many information is available, right? So make sure you learn from, or you get the message from a doctor who are trained in that field, or even they are expert in that field. That is much more better. And stop Googling so much, because when you have a headache today, if you Google now, you will have a brain tumor. So always try to consult, identify your sign. Example, Malaysians, I'm so sorry, including me, I have this tidak apa attitude. So don't delay, because certain things, when you never delay, when detected early, we can save and we give you a good quality of life. And be healthy, and then take your medication.
Okay, so those are the few take-home messages from Dr. Moven and from our podcast itself. So make sure, like I said just now, the aim of this podcast is to create awareness, because there's no point if the Ministry of Health, if the hospitals are opening up more, like more rampantly, but the patients are not coming to us, or they come to us in the later stages. That makes us difficult to manage. So thank you so much, Dr. Moven, for such an insightful session. I hope it's useful for all of the audience out there. ICB, intracranial bleed, can be silent until it becomes deadly. So we hope today's discussion helps to save lives by recognizing danger signs, early, acting quickly, and understanding when a headache is more than just a headache. Remember, headache, if it's constant, it's getting much more intense, and also associated with other symptoms such as blurring of vision, weakness. Please, but don't wait until you have the weakness. Anything you have headache, if it's getting much more intense, come over to the hospital. And before we end, just a final shout out to all our listeners, especially the medical professionals. If you think that today's discussion has sparked your interest in trauma care and also surgical emergencies, don't forget that Dr. Moven here will be speaking at my TESC. My TESC is a Malaysian Trauma and Emergency Surgical Conference. It's happening soon on 12 and 13 September 2025 in Doubletree Hilton, which features international speakers, hands-on learning, and also cutting-edge sessions in trauma, neuro, and also emergency care surgery. So today is the final day for early bird registration. So don't forget to sign up before the rates go up. We will tag the website, and also you can find out on MITSC Instagram. So to all of our Sinar Dailies audience, don't forget to follow all Sinar Dailies social media platforms and download Sinar Dailies new and improved mobile application. Stay tuned. I'll see you guys inshallah next month. Assalamualaikum. Bye.
Thank you, everyone.
Thank you.